Well, welcome and thank you for tuning in to this Prostate Cancer Foundation of Australia webcast on genetic testing and prostate cancer, an incredibly important topic. We want to begin today by acknowledging the traditional custodians of the land on which we meet, and we pay our respects to elders past and present. My name is Katie Clift. Very pleased to be moderating this panel discussion today on behalf of Prostate Cancer Foundation of Australia, as I said, into a very crucial topic on genetic testing and prostate cancer. We know that the connection between a man's genes and his risk of developing prostate cancer is very well established, but it's not very well understood. That's why we're bringing together a panel today to talk about what genetic testing is, what are the recommendations around it, the research into it. I mean, the data shows us that at the moment, about 5 to 10% of all Australian prostate cancer cases are caused by an inherited genetic risk, and about 10 to 12% of men with metastatic castration-resistant prostate cancer carry an inherited BRCA1 or 2 mutation. So a very important topic to know more about. We have a great panel of experts that I'm very pleased to introduce. First of all, Dr. Elena Castro. She is a prostate cancer medical oncologist from the University Hospital 12th of October in Madrid in Spain. Over the past decade, Dr. Castro has accumulated expertise in cancer genetics. She's worked on addressing the clinical implications of genetic and genomic variants in prostate cancer. We're very excited to hear about your research. Very honored for you to be joining the panel and going into that in more detail today. We have Bernie Riley, who's the head of telenursing and supportive care programs at PCFA. Bernie's been a nurse for about 20 years. His dad was diagnosed with prostate cancer, and he's dedicated his life and his career to Australians who are affected by the disease. So a great honor to have you as well, Bernie, and to hear more about the support that PCFA can bring. And Paul Bain. Paul, we are really, again, honored and very privileged to have you as part of the panel too, a prostate cancer advocate. Paul was diagnosed in 2020, shortly after his 50th birthday. He's currently living with advanced prostate cancer. He's an advocate promoting early detection. As I said, we're really looking forward to hearing your story and supporting men who might be affected with the disease and in a similar situation today. So we'll begin with a few opening remarks from each of our panelists, and then we'll open it up for a broader discussion. Dr. Castro, Elena, over to you first. And I want to start it maybe at a basic level. Let's talk about the connection between genetics and the risk of prostate cancer, developing prostate cancer. What do we know?
Well, prostate cancer is one of the solid tumors for which inheritance is more important. And it has been estimated that more than half of an individual's risk of developing the disease is due to genetic factors. So it could be due to alterations in genes clearly associated to cancer predisposition risk, such as BRCA1, BRCA2, that perhaps are more familiar to the audience because are associated also to breast cancer risk and ovarian cancer. Other genes associated with the Lynch syndrome that includes the risk of developing colorectal cancer, gastric cancer, endometrial cancer in women. So these cancer syndromes, but there are also other gene variants in other genes that are significantly more frequent in the general population. Each of these variants only increase the risk a little bit, but if someone has inherited several of these variants, then the risk would be much higher. Is what we call the polygenic risk. So the inheritance is really a very important factor for prostate cancer.
And when we talk about looking very specifically at genetic testing, why does it matter? I mean, how does it help influence treatment and some of the research that you've been involved with?
So currently, when we perform genetic testing, we only look at those, or we only look for those rare inherited variants in these genes associated to cancer predisposition syndromes. At present, we are not yet in the position of making any therapeutical decision based on the polygenic risk score. So this is still under development. For instance, for breast cancer is way more advanced, but currently we don't look for this in prostate cancer. But for the other alterations, it is important because, for instance, we know that patients with alterations, inherited mutations in BRCA2 have significantly worse outcomes than patients without those alterations. And now we also have PARP inhibitors, that is a type of therapy that works particularly well in patients who have alterations in genes involved in DNA repair. That is the case of BRCA1 and BRCA2. These type of therapies have been available for ovarian cancer, for instance, for several years now, but recently joined the therapeutical options for prostate cancer. So identifying those patients is important for counseling the patients in terms of prognosis, for follow-up, and also for treatment.
And maybe just part of the final section of opening remarks to learn a little bit more about your research. I mentioned you've been heavily invested in this for over a decade. You're currently looking at the clinical and molecular characterization of BRCA2 mutations, DNA repair defects. Maybe give us a summary or some insights into your research and what it's uncovered in the last few years.
Yes, well, we started by describing the clinical implication of these alterations in BRCA2. So first, we did a retrospective analysis when I was a research fellow with Professor Eels at the Royal Marsden in London. And then, this is how we identified that germline BRCA mutations were an independent prognostic factor. It was associated with higher Gleason score, with more frequent metastatic disease, but even within patients with those characteristics, those with BRCA alterations did particularly worse. Then we also analyzed what happened with patients with localized disease, and we noticed that the impact was exactly the same. So it is, and some other colleagues have also described this in other series. So it seems pretty consistent that these alterations are associated with poor clinical outcomes. So what we are trying to do now is trying to understand why. Why do these tumors behave the way they do? So we try to look into potential histological subtypes. That doesn't seem to be the cause. We have been looking at other genomic alterations that could be present in the tumors. We are analyzing transcriptomic profiles, immune profiles as well. We are trying to understand why these patients don't do well on treatments that for other patients work well. These are the standard therapies.
Well, you're doing incredible work, which we are going to dive deeper into in our open discussion on the panel. Moving quickly to you, Bernie. I mean, this topic, when people hear genetic testing, when it comes to cancer, I think there's a lot that's not understood. It can be very emotional. People aren't really sure what it entails, who should have it. What's your experience from the role that you have at PCFA?
Yeah, I guess it's an evolving area of prostate cancer, as Elena mentioned. It really has, just evolved over the past 10 years. It's something only in Australia that we're starting to do over the past 4 or 2 years, really, in metastatic prostate cancer. So there's a lot of unknowns, uncertainty in the community, amongst health professionals, and amongst all those people that we talk to. There's a lot of misconceptions about what actually mutations involve. Is it inherited, or is it something that's acquired over time? So this is, something that's not well understood by the people that we talk to day to day, and so something that we do as part of our telephone-based nursing service, helping people understand what their risks are. break down the disease and help them understand, what this means to them, and how there are treatments that can impact on these particular genetic factors. So, in terms of that, we help them understand that, genes are really just codes within each of our cells, and they help us control how that cell works. That's their role. And when you do a genetic test, you're looking for these abnormalities, these faults in these genes. Some of those are acquired over time as a result of what happens in a person's lifetime, their exposure to particular things as they get older. Sometimes the replication of those cells, the repeated cell damage, can cause mutations, and then there's the inherited mutations as well. So those are the faulty genes which are passed down from parents to their children over time as well. So we help people understand those issues and break that down for them, and then explain to them what's next.
I guess it's really important from that patient perspective too, right? Or families affected, and trying to make decisions about treatment or how they may handle the diagnosis that they have. There's obviously very many different stages, and where the genetic testing would be relevant in many cases. So part of your work, I assume, would be also explaining what it is.
Yeah, certainly. We help people understand what their risks are, what genetic testing involves, and how to access that, and the time points at which that's applicable. And then you're right, it's, prostate cancer over the past 5 to 10 years, and particularly in Australia, has really changed in the way in which we manage the disease. There are more treatments which have come on and available for men who are affected in the metastatic space. So new hormone therapies, new targeted therapies, and that really has changed the landscape and the way in which people move through each of those treatments. And it really is our job to explain, to help people understand where they're at, what's next, how that can impact, how to manage those things best, I guess.
Absolutely. We're grateful for your support and looking forward to more of your advice as we move through our discussion today. Paul, over to you. And we mentioned at the beginning a little bit about your story, but we would like to hear from you. I'll hand it over to you just to share your journey so far.
Yeah, thank you, Katie. And it's fantastic to be given the opportunity to chat to you guys today. This discussion is obviously really important to me on a couple of levels, but I guess my story began back in 2020 when I was diagnosed with a very aggressive grade of prostate cancer. I was asymptomatic at the time, just attending my local doctor for a checkup after I'd recently turned 50. Didn't feel like I had any significant health issues or anything at that time. In fact, quite the opposite, was always very active and kept quite fit and did most of the right things. So there's a point there to be taken, I guess. But certainly for me, once I discovered the journey that I was about to undertake, it was very interesting to get visibility into the amount of men, I guess, who are in the same situation as I have been, and the age of the men, which was something that was really quite of a surprise to me. It's, over time been a very stereotypical old man's issue, and I think Bernie would attest to that. But certainly the first time I visited my urologist, sitting in his waiting room, looking around, wondering what the heck was going on, it was really quite daunting, and I guess that started my journey towards advocacy and really wanting others to understand that this can happen to anybody at any time. You don't have to be an old man, you don't have to be sick. It can happen quite easily. So I've been through surgery, had a radical prostatectomy. Unfortunately, at the time of the diagnosis, that was really the only treatment option that I had, based on the Gleason grade 9 tumour that was discovered. That followed up with some radiotherapy. I still maintained a detectable PSA post-surgery, which is obviously an indication that there's still cancer cells present somewhere in my body. The levels were quite low at that point and not moving too quickly. So it was really just monitoring the situation on a 3-monthly basis to track any changes and then react as quickly as we could. Over the next 18 months or so, that remained pretty stable up until this year when we noticed a change again. That led to some more scans, and we have since found that the cancer has metastasized into my rib. So yeah, undertook some more radiotherapy earlier this year. Same sort of cycle repeated, a slight drop in PSA, steady for a few months, and just last week actually I've found out it's starting to move up again. So I guess I'm back in that cycle, and early in the new year we'll sit down with my doctors and work out what to do next. The genetics piece is really interesting to me. I have children, 2 boys. I haven't undertaken any of the androgen deprivation therapy yet. However, I'm certainly on the path to that based on the fact that the cancer keeps popping up in different parts of my body. And I think what has happened to me is probably an indication that I'm at a higher risk of developing the MCRPC. So where I am in my journey, if I had access to genetic testing now, that to me would be really, really valuable to get in front of that as early as possible. If there is an increased likelihood based on my history that I'm going to end up in that position, certainly from my perspective, the earlier we could go down that path, the better. I'm only just really recently learning about genomics and the impact that positive impact that testing can have, which I think is interesting in itself. I've been a really solid advocate, heavily involved with the PCFA, really involved in the prostate cancer community, and even I don't have a really great handle on what genomics can do for me. So I can't even imagine what it would be like for some of the men out in the country parts of Australia who we've helped along the way, Bernie, and spoken to during my advocacy journey, who they would have really no clue as to what opportunities might be there for them to increase early detection around the genetic issue and what that might mean for their families going forward. As we know, early detection is key, and it's been really something that I'm very passionate about helping men understand. So, genetic testing has never been offered to me through my medical team, which I'm starting to poke them about now. Again, I find that quite interesting. I do a lot of reading. I've learnt quite a bit about it and the benefits of it, and this is certainly helping me understand it some more. So I'm very keen to understand this some more and understand how it can help me going forward and other men like me.
And I think that's an important part of the conversation too, because as a patient and obviously a very outward advocate, you need to have that inward advocate focus too, right? And have the knowledge to be able to know what might be applicable to you, if genetic testing would be relevant. And I think it's really great that you've raised that point, that even in your situation, there's still a lot that is unknown or that you're discovering and trying to understand. And I guess, panels like this are helping to equip men and kind of give that knowledge and those experiences in order to progress this field further, and more research and more treatments. How do you feel? Yeah, and I guess what would your advice be maybe to men that are tuning in that may resonate with that and feel like they're a bit lost, they're not sure where to turn or where to look for some of this information?
Yeah, I think, and that's a really good point, because that's been one of the key points. Again, Bernie and Anne and the team at the PCFA is providing that place for men to go to find out what's happening to them. Where are they in their journey? What options do they have? And there's some amazing toolkits and other online resources that have been developed by the PCFA to help with that journey and getting an understanding. Through my initial advocacy, I was amazed by the amount of men, again, particularly in some of the more remote locations around Australia. Men don't like talking about their health in general terms, let alone some of the older generation men that might be out in small towns and find it very embarrassing to talk about prostate cancer and the mental side effects and also some of the physical side effects, which are really quite uncomfortable to discuss, around sexual dysfunction and those kinds of things, which men are just obviously not great at talking about. So giving them the confidence and knowing that there is a place they can go to find out what might be, what might happen to them next and what options they might have for some treatment it's been paramount. So early detection is really just something I'm, again, so passionate about. I have boys and I have concern for, the likelihood of them developing this disease later in their life. And I really need to understand what it means for them and what we can do ahead of time to make sure that we give them the best possible chance to understand, the risks and implications of me having this disease. And again, relative to the genetic testing, I think, we have subsidies available for men at a certain stage of their journey. I still think there's an opportunity for us to improve that. Again, I may be a classic example of that, where most medical opinions would be that I am on the path to metastatic castration-resistant prostate cancer. So, again, it looks like that's where I'm heading. And if there was an early opportunity for that to be determined and allow me to have access to the genetic testing, that would certainly be fantastic for me.
Maybe, Bernie, let's pick up on that, because you referenced where we're at in Australia. Of course, we have an international panel today. Elena is based in Spain and has done some incredible work internationally all over the world with her research. And it differs where people are. So what are we looking at in Australia? People are kind of just tuning in and thinking, what's relevant for me? What's the current state of play?
Yeah, good question. And thank you, Paul, for what you're doing out there for men, and thanks for being here today and sharing your story. I guess, picking up where Paul was talking about, where genetic testing is subsidised in Australia at the moment is in that metastatic castrate-resistant space. So, and let me explain that for the people who, these are these confusing terms that we quite often use, and these are the things that we try and explain to men. So when men's cancer it metastasizes, quite often they'll go on to hormone therapy, androgen deprivation therapy, or ADT, and at some stage their cancer may progress while they're on that therapy. So their PSA may go up and they may develop cancer in other sites of their body, despite their testosterone being suppressed during that time. And that's what we call metastatic castrate-resistant prostate cancer. So in Australia, at the moment, since about April 2022, the government approved Medicare-funded or subsidised testing for two particular mutations: the BRCA1 mutation and the BRCA2 mutation for prostate cancer. So if men can have that as soon as they become castrate resistant. And quite often what will happen is if there is some tissue available, you would test that tissue. Sometimes that's tissue which has been from a radical prostatectomy, sometimes that from a biopsy, and sometimes that's a fresh sample of tissue. If that tissue is not available, if a person doesn't have that tissue, then they may be eligible for a blood test under Medicare as well. So I guess that's where we're at the moment. There is other genetic testing out there as well, so for men who have a strong family history, there are guidelines for GPs and for specialists to refer to familial cancer clinics. So if you have 2 or 3 first-degree relatives with the same cancer or prostate cancer, you're eligible for referral to a familial cancer clinic. If you have one, and particularly one or two members of your family who have prostate cancer, and one of those is below the age of 50 or diagnosed below the age of 50, then that again is in the guidelines to refer to a familial cancer clinic. And equally, if you've got a known history of a genetic mutation which predisposes you to cancer or prostate cancer, BRCA1 mutation, BRCA2 mutation, and some of the other mutations which Elaine has mentioned. Those are all points at which you might be referred to a familial cancer clinic to start that process. So that's important for men to know their family history in that regard, and that's quite often a starting point that some men might be referred by their GPs if they have that strong family history.
And I think back to the point that Paul made too about understanding this even from a basic level, to be able to ask those questions in some cases, and advocate for themselves in health professional settings. Elena, let's zoom out a bit, because obviously referencing the fact that your research is international, and we said that this topic is very different in very different parts of the world, but it also influences, as a lot of international research does, perhaps how things will progress in Australia, or the emerging treatments that will come out for men with prostate cancer globally. So from your perspective, I guess, what do you see from an international lens, and how genetic testing has influenced your research?
Well, first, allow me to make a comment on what Bernie just explained, because I understand sometimes it's very confusing for people. Sometimes we refer to genomic testing and genetic testing. So when we discuss genomic testing, often we are discussing the analysis of the tumor, and genetic testing the inherited mutations in the blood or in the saliva. This is very technical. So currently there is a recommendation, is the international recommendation. I'm not very sure how it is exactly in Australia, but for all men with metastatic disease, it doesn't matter whether it's castration resistant or hormone sensitive, to undergo germline testing, trying to understand whether they have inherited mutations or not, because it is important for treatment, but more importantly is very relevant for familial risk, to understand the familial risk, as Paul was saying. And then we also have the genomic testing that currently is very restricted to castration-resistant disease, because we only have targeted therapies, these PARP inhibitors, at present for a castration-resistant disease. This may change soon, because these therapies are also being developed in earlier stages, but we still don't have those. So this may change when we have therapies. But if someone has metastatic disease and has not been offered genetic testing or this germline testing, they could ask, because very likely they will be candidates for that. For patients with localized disease, as Bernie just explained, the testing is based on family history of prostate cancer or other tumors. And sometimes in some groups, we know that some mutations are more frequent. For instance, in individuals with an Ashkenazi ancestry, there are some funder mutations, and they maybe offer genetic testing. And then also depending on some characteristics of the disease. But I know it's complicated, this difference between analyzing the tumor, we do that for treatments, and analyzing the inherited variants or mutations, that we do that for the familial risk. So one of the things that these are something that is going to change. You were asking me, how are we moving forward with this? This is going to evolve as we have more therapies. We are also trying to find a way to integrate both tumor testing and the germline testing, because one question is, do we need to do both for all of our patients? And the thing is, if we were able to do the analysis of the tumor for all of our patients, we will be able to identify most of the inherited variants. So we could use this analysis of the tumor to identify who are those patients that need to be referred for genetic testing. But at the moment, as you just mentioned, we are still in the process, and sometimes perhaps the safe we say that everyone should have germline testing, and if candidates for targeted therapies, all those patients should get the tumor analyzed when they become currently metastatic castration resistant, when they get metastatic castration resistant disease.
And that's important to sort of indicate where things are headed. What do you hope to see in this field? What are some of the elements, I guess, that you hope to see progress and develop in the next few years that would influence the research and then influence greater treatments?
Yes, well, we need to understand exactly the characteristics of those tumors, because that will help us identify new targets that may work particularly well for patients with these inherited variants. But one thing that we are going to be very soon is these PARP inhibitors moving to earlier stages. And what I hope with that is that it also improves the outcomes of our patients. So these therapies are being now moved to metastatic hormone-sensitive disease that, as Bernie explained, is when patients with metastatic disease start the androgen deprivation therapy. So at the beginning of their journey. So PARP inhibitors are being moved there, and even for localized disease, but the studies are just starting. And the other thing is, unfortunately, patients become resistant to those PARP inhibitors after a period of time. So how are we going to do when that occurs? So how are we going to overcome resistance? So first we need to understand how the resistance happen, and then how are we going to deal with that? And which other treatments can we offer to those patients after the PARP inhibitor? For patients with alterations in mismatch repair genes associated to the Lynch syndrome, now we have good evidence that checkpoint inhibitors, immunotherapy, may work very well. And so it's important also to have patients tested for these mismatch repair mutations, because we are starting to have specific therapies for patients with particular mutations or alterations in particular genes.
Absolutely. And this is also about being able to guide those targeted therapies, right? And precision medicine that will develop for particular types of prostate cancer for men. So that's a very promising outcome and development in terms of that precision medicine and what these results can kind of lend themselves to in terms of that for your research. Paul, maybe coming back to you for just a moment, because I think part of the work that you're doing in advocacy is obviously putting forward this important point of raising awareness of people. Obviously, when they donate to Prostate Cancer Foundation of Australia, it goes toward advancements in research, like we just heard, like Dr. Elena's work. What does this mean to you, this discussion about research in the future and what you hope to see in incoming years?
Yeah, firstly, I'd just like to say thank you in general terms to Elena. Like, just listening to you speak and the incredible work that you're doing, yeah, it really resonates. It means so much. So thank you. And I know there's many others like you, and we're very lucky to have people like you that are focused on this. Yeah, look, I think for me it's a very simple message, and it's really just about awareness and understanding. So men understand where they can go to get the information that they need. It is very daunting, particularly if you're thrust into the environment or the community, as I like to call it, you know, unexpectedly, and not really understanding what is in front of you. You know, there are many levels of what that journey might look like going forward. So really having access to information is key, and just being aware of where to go and you know, what resources are available to help you through that. And I think even in the last 4 or so years since you know, I've been on this journey, I've seen a significant change in the landscape of prostate cancer awareness. I've been involved in a lot of advocacy activities and some different media interviews and things along the way. And I've helped Bernie create some artifacts for men in the country and different things like that. So I've seen a change just in that short time. So it's really encouraging. While we have the incredible and brilliant minds like Elena working behind the scenes on the science, which is just, it blows me away, and I'm so grateful. At the I guess the forefront, we still need that basic understanding for men to know that it's okay to talk about it, despite the uncomfortable subject, and again, some of the really, tricky issues that men don't like to speak about in general terms. So, and then there's again, I've mentioned a couple of times during this session, it's really important for people like me to understand how I might best prepare my family, going forward, what it means now for my children, that I'm in this situation, and obviously that's that's important to all of us. But my boys are going to have an increased risk of inheriting this disease, so I need to understand what that really means and what I can do now to help them.
And this is a difficult conversation to have, I'm sure, with family members, but also bringing up the very issue of family history of prostate cancer. And I know we've talked about it a couple of times already in our panel, but I think it's very common in Australia too that people just don't want to know in some cases, or don't want to explore the information. I guess, what would your advice be if we have people listening that aren't really sure if they want to know more information? I mean, I feel like knowledge is power. It comes from my experience. And I wonder if you would have a similar thought, or what your advice would be to men if they find themselves in that situation, given what you've experienced.
Yeah, that's such a good point. And I have found it helps you find your peace with wherever you are in your journey, whether it's a mortality discussion, whether it's treat and live with it and die nice and old and peacefully, or whether it becomes more serious. I think understanding where you fit into that obviously comes from a lot of knowledge. Again, I can't stress enough that it's so important for men to somehow find the confidence to talk about it as much as they possibly can. There are some really horrible side effects. Let's break it right down to the simple facts of things like incontinence and sexual dysfunction and all those things that are just like, oh my goodness, men hate talking about that. But I find that almost empowering to stand in front of people, or in the media, or on TV, or in a forum like this, and say to men, you know what, it's okay. There's plenty of people out there that are in your position. There's also a lot of people out there that are a lot worse off. And that's kind of my view of it. My journey is uncertain. The longer it goes, the more uncertain it seems to be coming. But the more I can do in the interim to just reassure men that, there's a lot of us out here of all ages, not just, more senior gentlemen, from all walks of life in all parts of the country, with all levels of support. And I guess that's another a real significant thing from my perspective. There are some men out there who might not have a large family structure around them. They may be divorced or never married, or don't have children nearby, or they live in small country areas, which we've talked about briefly, who aren't as lucky as perhaps someone like me, who has a very close-knit family. I've been lucky enough to establish an incredible relationship with the PCFA, and I guess have the personality and the comfort level to be able to talk about it, which I think helps from that perspective. But there are lonely men out there who come home from a radical prostatectomy to an empty house, and then they just have to have that external level of support, and going through that experience, I just can't imagine what that must be like. So it's all the elements of I guess, support, from awareness to understanding what people might be going through, to letting them know that it's okay to talk about these really taboo subjects. And there are, if you're suffering from things like sexual dysfunction, there are options, there are treatments, there are programs, there are people you can talk to about those things, and you don't have to sweep it under the rug and be embarrassed by it. You can find your peace with it, and you can, just really, there are lots of good places to go to find the information that you need to make the best of whatever situation you've found yourself in.
Paul, it's my turn to compliment you, to say that you're one of the most articulate advocates that I've had the pleasure of speaking to in the cancer space, and really encouraging that key component, you know, the awareness, the early detection, and empowering men. I'm blown away by the comments you've made in our panel today. We've talked about that awareness factor. On the bookend, I guess, in one way, there's the research and the progression of that, and that's crucial to the future that we're going to see in Australia, internationally, of prostate cancer and how it's treated. Bernie, let's zone in then on the support factor. So, I mean, if men discover they have a family history, what do they do next? I mean, I mean, maybe that's a very broad question because it would differ very specifically. But if people are empowered to get this knowledge, maybe they discover, for example, they have a family history, what's next in terms of support and these next steps?
Yeah, I guess then it's about understanding what they need to do with that, where they need to go. And so, that's exactly where, PCFA fit into the picture. So helping men and their families understand what they need to do next, and whether that's in, screening for prostate cancer. So I guess, men who have that family history of prostate cancer should begin PSA testing at an earlier age. And we talk now, and the guidelines currently are being reviewed, and what they are at the moment is, begin PSA testing for the early detection of prostate cancer at 40 or 45. And I guess, they should know that the threshold for further investigations is lower. So a PSA of 2 as opposed to a PSA of 3 in a man over 50 is that threshold for further investigation. So understanding when they need to be tested, what their results mean, and what are the next steps are the really important things. And finding out that there are other people out there that are in a similar situation. So, what we help men link into is other men and other families are in that situation. So whether that's through support groups, whether that's through peer-to-peer connections, a Mates Connect program where men talk to other men who've been through particular treatments, or whether that's online forums like Facebook support groups and online forums. So that's where we help link men with support, and men and their families with the support that they might need early on, and throughout the whole disease trajectory.
Yes, and I was going to give a nod to the fact that the telenursing and the nursing services, the prostate cancer specialist nurses, there's a whole suite of different support network and support services that PCFA offers. So people can reach out to find what's best for them.
Absolutely, 100 nurses across Australia and health centres across Australia, and the telenursing service and counselling service fills that gap for those men who don't have access to a face-to-face nurse out there. But if men do need support, it's as simple as picking up the phone to PCFA 1-800-220099 and giving us a call, and we'll link you with the support that you might need wherever you're at.
Absolutely brilliant. We'll move to closing remarks. Dr. Elena Castro, I mean, we've talked about the last few years for you and what you hope to see in future. What would your message be to men that may be listening, perhaps health professionals or patients affected by prostate cancer, in terms of being involved in the research, what they can do to I guess, support developments of where it may go in future, or a message that you'd like them to leave the panel with today?
Well, I love what Paul just said, that it is very scary for anyone to be diagnosed with cancer, but for some reason also seems to be very difficult for men to talk about prostate cancer. It's probably a cultural thing, is due to multiple factors. So there is a lot that we need to do, men with men, but the whole society, to support men with prostate cancer, so they feel that they can really talk about what they are going through, and we need to support these men. And I think this is something that is very much needed, because we have been able to overcome this kind of embarrassment and very difficult situations with other tumor types, for instance, with breast cancer in women. And I think, why not? We can do the same for men with prostate cancer. That will be huge. So we can all support these men, and men with prostate cancer can participate on trials, on different types of studies that will help to move research forward and to move treatments and to move different initiatives and that are very important. So it could be to have better treatments, it could be to improve quality of life, it could be to diminish side effects. There are different types of studies. These are all important, and we need these patients to participate in those studies.
Absolutely. And thank you for the incredible work that you do and sharing so much with us today. Bernie, back to you for final thoughts. Genetic testing and prostate cancer, what would you like people to leave this discussion with?
I'd like them to leave with the, feeling that they can ask these questions of their health professionals, so that they know where to go for genetic testing, or they feel confident to ask that question of, is this right for me? Is this something that I should consider now? Where does this fit into where I am with my prostate cancer? So I'd like men to, feel empowered to ask that question. It's really important that we continue to ask questions along the way. Where am I up to? Every time there's a change in your disease condition, feel comfortable asking your health professional, okay, these are the options. Are there other options? Are there clinical trials? Is there genetic testing? Is there something else that we can consider which can help me get early access to something that may be beneficial to me along the way?
Brilliant closing words. And Paul, over to you for closing us out.
Yeah, again, look, I think just having the opportunity to participate in this forum is testament to the recent progress that we've made around awareness and having the ability to talk about this and help men understand that they're not alone when it comes to this kind of thing. And there are some amazing resources and just some incredible people working diligently to try and come up with some answers to help. From my perspective, the advancement in awareness has been significant in the last few years, but we've still got a ways to go. And even just listening today, I've learnt some things about what I might be able to do, relative to my next steps, and getting a better understanding of what's happened to me and what options I might have in my near future. So even from a very personal perspective, this has just been an incredible forum. But I would certainly just like to, I guess finish with the fact that, if anybody is listening out there and they have men in their life, the simple message is to get tested. It's never too early. If your GP is reluctant to perform a PSA test because you're asymptomatic, for example, which has happened to friends of mine along my journey, walk across the road and find somebody else, because it really can be important that, every day can make a difference. My journey has unearthed some really close friends who didn't realize they had some issues. They got tested after learning of my situation, and some of them have had to go on and have significant treatments themselves, which is potentially something they would not have done had they not had that conversation with me. So it can be that simple. It really is very important. It's not a sexy disease. It hasn't in the past had the public exposure as some of perhaps the other cancers have had, but it's fantastic to see lately in the public domain. It seems to be becoming more common to see organisations and public platforms supporting the cause. So yeah, it's we're on the right track, I think. But I can't thank Elena and all the amazing people who are doing the kind of stuff that she does behind the scenes. It's terrific. So thank you, and thanks everybody for giving me the opportunity to again share my journey, and hopefully someone out there is had a thought bubble now and might get themselves along to the doctor and get a test, even if for no reason.
That's why we're all here. We talked about awareness, we've talked about support, we've talked about the future of research. Thank you so much, Paul, Bernie, Elena, for your insights and being part of this panel. And for those of you who have tuned in, if you have questions about genetic testing or would like to have more information about the full suite of support that PCFA offers, you can visit pcfa.org.au. But thank you to our panelists, and we'll see you next time.